Welcome to the Heart of Healthcare podcast. Hi, listeners, and welcome back. Today, I'm talking to Ann Somers Hogg, who is the Director of Healthcare Research at the Clayton Christensen Institute. She focuses on business model innovation and disruption in healthcare, including how to transform a sick care system into one that values and creates total health. Quick background in the Institute for listeners who are unfamiliar. The Clayton Christensen Institute, it's a nonprofit, nonpartisan research organization founded on the theories of late beloved Harvard Business School professor Clayton Christensen. His work guided and influenced folks like Steve Jobs and Jeff Bezos, and his theory on disruptive innovation was called the most influential business idea of the early 21st century by The Economist. While his work can be applied industry-wide, his book, The Innovator's Prescription, is specifically about healthcare and is an absolute must-read for any healthcare innovator out there. Ann Somers, welcome to the show.
Thank you so much for having me, Hallie. I'm really excited about this conversation.
Yes, likewise. And I love following the work you're doing, the reports you're putting out. So thank you. So speaking of reports, a few months ago, you put out a report called Zero Inflation Healthcare. Tell us about your findings and suggestions for scaling insurance innovation.
Yes. So the first thing I will say is what I knew about health insurance before this report was minuscule compared to what I feel like I learned in the research process. So I actually started my career in strategy consulting for health insurance companies. And so I felt like I had a pretty good grasp on how health insurance business models worked. But going through this research process really just opened my eyes to how the ecosystem as a whole works. And therefore, based on Clay's theories, really what are the levers we need to pull if we want to transform the system for better? So the first part of a research effort is often, okay, what's the problem that we're trying to tackle here? What's the problem we really want to see solved? And with this work, it was addressing systemic, out of control healthcare cost inflation. And to go about coming up with how we might achieve something, a moonshot as big as zero inflation healthcare, we really looked at the problem through the lens of Clay's theories. And to do this, we really leveraged disruptive innovation and business model theory. And I think to kind of highlight some of my findings, it might help if I call out some of the things we saw and then sort of what we suggested as the path forward. Does that work?
Yeah, let's go in. Let's dive in.
Okay. So top line, healthcare cost inflation is a systemic problem, and systemic problems require systemic solutions. So our proposal was that a solution to curbing healthcare cost inflation was pairing business model innovation with a new value network. So what do I mean by that? Effectively, a value network, if people aren't familiar, is the commercial ecosystem of suppliers, partners, other organizations, regulations, et cetera, that surround a business model, because businesses don't exist in an ether. They have to be surrounded by a value network that enables their success. And when we think about what's the business model innovation that's really going to solve the problem of systemic healthcare inflation, what we called it was the optimal care business model. So this is a health insurance solution that's powered by a health intelligence platform. And the way that we got to that conclusion was if we really think about the cause of unsustainable inflation, it's the four-party economic system that enables it. Again, systemic problem needs a systemic solution. It has a systemic cause. And perhaps oversimplified, we said that these four parties are insurers, employers or sponsors, providers, and individuals. And because of this complex ecosystem that is insured healthcare, innovators can't just out of the gate say, I'm going to change the system, right? That's just too much to tackle. So instead of focusing on changing the system right out of the gate, what we suggest is that innovators or entrepreneurs really focus on tackling the three key consequences that the system creates. And we framed those as one, the insurer's cost plus business model, right? Incumbent insurers make more, they spend more to make more. The second is weak market forces. And then the third was no supply chain visibility. So weak market forces are really important because they don't drive innovation. And when there's limited competition, existing players really have no incentives to innovate. So in order to identify how one could innovate in this environment, we looked at past innovators to see why nobody had unseated the incumbents at scale. Because it's not like nobody has tried. It's just
like
nobody
I'm sure
succeeded.
you looked at Haven, I'm sure.
Yes, that was on our list. And so we looked at who's tried, what worked about what they were trying, because it's not like the people or the innovators or the entrepreneurs who attempted to make change just all out failed, right? There were some things they all did right that innovators and entrepreneurs can learn from. So we looked at a number of different companies, a number of different business models to identify what went wrong, what went right, and what can innovators learn from that.
First of all, I love looking at those who have tried through the lens of like, what can we learn? Because we don't do that enough in healthcare. I think there's a shame in failure versus failing in a way that's smart, where we can kind of take away key learnings and share those so that others don't make the same mistakes.
And in doing that, first I'll talk about InsureTechs. So we looked at, the InsureTechs. What did they do right? What did they maybe not do so right that has not led to viable business models to date and hasn't allowed them to disrupt to date? And one thing, because I remember when many of them came to the market in the early 2010s and I was looking at disruptors in healthcare, I thought, oh, these are really promising. Like, we really got to watch these. They're really going to take off for a number of reasons.
Like
and then
Clover and Oscar? Those are the ones that you're talking about?
Entities like that, yeah. And then in retrospect, right, hindsight's always 20/20, having a very different perspective. But two things that I'll highlight. One, in insurance broadly, and also in health insurance, without scale, it's really hard to succeed. And new entrants in health insurance really struggle to enter with scale. So one, that's really a challenge. The second, a lot of these InsureTechs, Oscar, Clover, Alignment, et cetera, they entered and they focused on Medicare Advantage customers, which from a growth perspective is really smart, right? The baby boomers were all aging into Medicare. It was a growing market. It looked like an awesome place to focus. But then if you step back and you don't just focus on growth and you actually look at the problem through the lens of disruptive innovation and Clay's theory around how disruptive innovations work, what InsureTechs did was they went after incumbents' best customers, right? So Medicare Advantage is a really lucrative offering. And when new entrants, potential disruptors, go after incumbents' best customers, the incumbent is poised to fight back. And they're likely going to win, because really what they're doing in that situation is not entering a disruptive innovation fight. They're entering a sustaining innovation fight. And disruptive innovation is a theory of competitive response. And it tells us that in those situations, incumbents are likely going to fight back and win. So going after incumbents' best customers may have been smart from a growth perspective and from a total addressable market perspective, but through the lens of disruptive innovation, not the wisest move.
Yeah. So, I mean, just to even step back, disruptive innovation theory, it's all about how a product or service moves from, we say, it's like the bottom of the market, up market, to like eventually displace the competitors, the incumbents that are there. Like, how do you see that theory specifically manifesting in healthcare today, just even beyond insurance? Like, are there examples that our listeners can hear about so they're like, oh, okay, I get what disruptive innovation is?
Examples that probably your listeners are familiar with. Women's health is a huge area where there's a lot of non-consumption. So that means that there are people in the market who aren't consuming solutions because nothing is either affordable or accessible to them. And non-consumption is a huge opportunity for disruptive innovations because it allows innovators and entrepreneurs to enter the market with something that could be perceived as not good enough to existing customers who are buying things in the market, but it serves an unmet need. And one example that I love is MIDI Health that focuses on menopause care for women.
That's what came to mind for me too, as you were describing that. Yep.
Because there is a huge swath of the population, 51% in fact, that goes through menopause, and there aren't a lot of offerings for that. So MIDI Health has recognized that, and I would say is doing an incredible job serving the non-consumption and a clear need in the market. So non-consumption is one place where we see disruptive innovations. You also see them at the low end of the market where existing products are just too inaccessible or too unaffordable. And so people don't have access to the current solution. And a place where we're seeing a lot of that is in fertility care. A place where a lot of people are priced out of the market. And because of supply constraints, there's just a lot of inaccessibility.
Yeah. Got it. Okay. So
Yeah,
now we get disruptive innovation theory. Thank you for that tangent. Okay. Back to InsureTech and why it's harder to enter and succeed for the startups.
Yeah. So we mentioned that disruptive innovations tend to enter at the bottom of the market, either non-consumption or in a low end, lower cost way. And Clay would always say that there are 4 things that are required for successful disruptive innovation: an enabling technology, a business model innovation that surrounds that technology, the value network that enables the business model to succeed, and then the regulations that support or prohibit innovations. And in health insurance specifically, regulation really makes entering at the low end of the market effectively illegal. And that's not a value judgment on whether that's good or bad. It's just a fact. And that's because of things like the requirement for 10 essential benefits. So whereas in other industries and other markets, innovators could enter with a not as good as product or something that wasn't, going to serve high-end customers, that's effectively illegal in health insurance.
The bronze product itself is still quite comprehensive. Yeah.
Right.
You can't do anything lower.
Yeah. So regulation really limits low-end disruption in health insurance.
Yeah. So do you think that within the health insurance tech that folks, Oscar's doing well now. We have some examples. So how do you think that this has kind of played out?
Yes. And actually in the report, it came out not long after Oscar had their first profitable quarter. Yeah. And I think, yes, they're really turning it around, which is impressive. I would say it seems, based on what I've read, that where they're making their money is not necessarily where they started out thinking that they would make their money, really on the insurance side, but more so on the tech side.
Right now, we're having a moment in healthcare and health insurance specifically where there's just such a distaste for the incumbents, specifically United Healthcare. But all of them really are in the public eye as fairly or unfairly the reason why healthcare is messed up in this country. How could these incumbents possibly crawl their way out of the reputational hellhole they are in?
That's a great question, and it'll be a really long crawl. Because part of the struggle, it's not that, and Clay used to say, it's not that the leaders of incumbent companies are bad leaders and that's why they get disrupted. They're actually really good leaders that are good at keeping their existing business model functioning the way it was developed to function. So if incumbents want to crawl their way out of that negative public perception, the pathway to that is business model innovation. And that's harder and harder to do the longer a business model exists because, and when I say business model, there are tons of different ways to talk about a business model, but we're thinking through the lens of Clay's 4-box model, which is the way value propositions, resources, processes, and profit formulas work together in order to create value. And the longer business models exist, the tighter and tighter those 4 parts become, and the more resistant they become to change. So I don't want to say that it seems almost impossible for incumbents to do that, but it'll be a really challenging, really long road.
Is there anything that you hope to see in the new administration around, and let's continue the conversation around insurance and insurance innovation. Are there any like hopes and dreams you have, that things that they can make happen that would improve the system to work better for everyone?
Hopes and dreams, yes. So I'll get back to what you said about Haven and how, they set out to transform healthcare and transform health insurance, and they were going to make it so much less expensive. And do you want to just explain how Haven came together? And yeah, so it was the leaders of J.P. Morgan, Berkshire Hathaway, and oh my gosh, I'm blanking on the third, Amazon. Yeah. So the leaders of J.P. Morgan, Berkshire Hathaway, and Amazon came together and said, we're going to make healthcare less expensive. I think it was Warren Buffett's quote around, like, it's the tapeworm, right? It's eating away at America. But they didn't succeed. And
Atul Gawande was at the helm. So they had exceptional leader, exceptional, 3 amazing companies with huge employee base and presumably more market power than a startup coming up from scratch.
Absolutely. And at the end of the day, despite the fact that all of those companies as self-insured entities pay a ton of money in their healthcare benefits, healthcare and healthcare coverage isn't mission critical to what any of those companies do, right? It's not part of their reason for being. And even as large self-insured entities, their scale within the entire healthcare ecosystem was a few million beneficiaries. So that's not enough to really shift a system that in aggregate cares for 330 million people. And in the report, one of the things that we highlight was how if a new value network is going to be created where innovative business models can succeed that are focused on the best care at the best cost every time, if that's going to happen, then the government has to play a role. Because as the largest payer, the government has the ability and the scale to move the market. So we see that happen today. And for entities like CMS or for state governments who are really focused on what are the benefits that they're providing their employees, and they have budgetary requirements to, balance the budget every year. For those entities, it's mission critical for healthcare to be more affordable. Whereas that wasn't a requirement for the companies that made up Haven. It may have been something their leaders set out to do, but it wasn't mission critical to the entities. So I think my hopes and dreams for this administration would be to realize that if you really want to make healthcare sustainably less expensive, trying to take cuts through efficiency innovation and saying, find a way to cut millions of dollars out of the budget over 10 years, that's not going to solve the problem, because we can't efficiency innovation our way out of this. We need a system transformation if we really want to see sustainable change, if we really want to see healthcare cost inflation slow down, if we really want to see paying for health and not just paying for sick care.
Yeah. Which CMMI has been a leader on in many ways. So does system transformation come from more regulation, different regulation, or less regulation in healthcare?
That's a great question. And I think it probably depends on the component of healthcare. So I don't think there's a sweeping answer. I think there are places where less regulation would probably be beneficial to innovation, but I don't know that it would yield quality-focused business models.
Yeah. What about the medical loss ratio and thought about, can you, for our listeners, just explain what it is and how that has impacted health insurance and the business of healthcare?
Yes. So the medical loss ratio effectively tells insurers that they have to pay out 80 to 85% of the premiums that they collect in the form of medical care. So
sounds great, right?
Sounds great.
Sounds great.
In theory.
Yes.
But effectively what that means is that insurers will spend more to make more. So that's not really a way to create health or to lower healthcare cost inflation. And interestingly, when the medical loss ratio was developed, spending on things like social determinants of health or drivers of health or things that we know to improve health, those aren't considered part of the numerator. So they aren't medical spend. They're considered administrative costs, which actually means that there is a disincentive for health insurers to invest in things that we know help people's health outcomes. Additionally, when we think about things like quality improvement, which is also part of the numerator in the medical loss ratio, things like prior authorizations count as quality improvement. So there's an incentive for insurers to go through the whole process of prior authorization, even though 97% of things get approved.
Yeah. So in theory, we love the idea of making sure that they're not just profiting by denying care and not spending money on care. However, the formula needs refreshed, perhaps.
Right. The math doesn't work. The math does not incentivize the desired outcome.
Yeah. Well, maybe there's a chance for that. Maybe that'll change.
That would be good. That could be something.
We can add that to our hopes and dreams for this administration.
Yes.
So back to some of the theories that you are like living and breathing every day. You know, the theory that I think gave me the biggest aha moment in business school was the jobs to be done theory, which encourages us to think about how people hire products or services when jobs, quote unquote, jobs arise in their lives. And it's a way to think about the relationship in a way that I hadn't before I was introduced to the theory. And of course, the milkshake story comes to mind for me. So the team was hired to help this fast food chain improve milkshake sales. And first they tried to look at how they could improve the product on flavor and price, but nothing budged. And so then they looked at what job the milkshake was providing. But they found that people were drinking milkshakes in the morning on their way to work because they needed something that they could consume with one hand. And I know it's actually really hard to eat a Starbucks sandwich with two hands, but they needed something they could hold with one hand and kind of keep them occupied on their drive to work. A boring drive, a milkshake helps. And so, I mean, it just stuck with me, I think, because it was like just a big aha moment, but also just being like, I can't believe people are drinking milkshakes in the morning. So anyhow, I know you apply this theory to healthcare. Would love to talk about it in relation to some of the research that you've done. And I know that recently you did a study on childhood nutrition. So maybe you can tell us about the job to be done there.
Yes. I love jobs to be done theory. If I had to pick a favorite one, that might be mine. But you highlight it well with the milkshake story. Maybe a few more details for folks on how it works if they aren't familiar with it. Top line, there are no impulse purchases. There are always reasons why consumers buy things or act the way that they do. And jobs theory is really a theory of consumer behavior. So it helps us uncover the causal drivers that lead customers to buy the things they do or act the way that they do. And in short, a job to be done has two parts. It's the circumstance or the situation that people find themselves within, and then it's the progress or the outcome that they're seeking. So with the milkshake, the job to be done is when I have a long, boring commute, help me consume something that will keep me full till lunch that I can hold in one hand, or help me consume something that I can hold in one hand that'll keep me full till lunch. right? So these people needed something, like you said, to fill their long, boring morning commute. And jobs to be done have functional components. So the tangible outcome people are looking for. They have emotional components. So the way that people want to feel. They have social components, the way that people want to be perceived by others, that lead people to hire or buy certain products or services in order to get those jobs done. And there's a struggling moment in every job to be done, and that's really the seed of all innovation. So when we looked through the lens of jobs to be done with some recent research, we tackled the topic of sugar-sweetened beverages. So it's not news to folks that we consume too much added sugar in the United States, and this is a problem for everybody, but it's especially bad for kids, and sugar-sweetened beverages are the largest contributor to kids' added sugar consumption. It's also, there is an equity issue in consumption. So Black and Hispanic populations, especially those in lower income brackets, consume more than white counterparts. So our research sought to uncover what leads parents and caregivers of kids between 5 and 12 to say, I'm actually going to stop giving my kid sugary drinks, and I'm going to choose something else. So when we think about healthy behavior change, it's really informative to learn from the people who have made the decision you're seeking to understand. Because by understanding their stories and understanding the language they use and really the causal drivers behind their behavior, then you can take that knowledge and package it to help providers, public health officials, policymakers to really spur that behavior in other parts of the population.
That makes sense. I mean, you're thinking about serving how you would serve them before they made that change.
Yeah. So how can you really,
it's like their prior self. Yeah.
Yeah. How can you incentivize people to, or not even incentivize them, but how can you speak to them in a way that helps them realize that hiring the non-sugary drink is actually going to get them the progress that they want?
So how do we do it? What did you uncover?
So that's probably a podcast in and of itself, but top line, I can share some things that really surprised me.
Yeah.
So one, it's never about the cavities. So parents often will notice that their kids have cavities, and it's kind of an indicator that, oh, maybe they should change their beverage consumption, but it's never the reason they change. It's much health concerns, both near term and long term, are much bigger drivers, as is, not surprising probably, parental guilt. So parental guilt about either the parent having already changed their behaviors and stopping to no longer drinking soda, but still letting their kid do it. That's a huge guilt driver. People hearing that their child has a health issue, whether that's something like a biomarker being off or they're visibly overweight, that drives a lot of guilt. And then I would say another surprising thing was price was not the driver that I expected it to be. It was mentioned by a couple people as being a reason that they had purchased more sugary drinks in the past, but a number of people actually said they were surprised by how non-sugary alternatives were actually less expensive than, say, brand name soda. And so to them, that wasn't necessarily the reason to change, but it was a delighter.
I have my personal story that I've shared on this podcast before of, my parents put soda in my bottle. I have a picture of myself when I was just a few years old with, holding a bottle with soda. And then I think I had some crackers in my other hand. And
I have heard you tell that story.
Yeah. I mean, it's like, it's something that like was a big part of my life for a very long time. And our only rule in the family was that you couldn't have a soda before noon. Other than that, it was like as much as you want. So soda was a big part of my life until I gave it up in business school, actually. And it was the hardest thing I've ever had to do was giving up soda, and I haven't had one now in many years. And I'm very proud of that, but it was really challenging. So going up against something like that is really, really hard. And who is that person that can support a parent in making that call, especially if the parent also is used to consuming? It's part of their life. So you're not just, you have a behavior change for a child, but the person who's responsible for that child's consumption it also has the same consumption patterns.
Yes, absolutely. And that's where the emotional drivers, and I would say the social drivers too, were clearly sometimes more important than the functional outcomes that parents were looking for. Yeah. So it was, I don't want my child to have childhood diabetes or even have diabetes when they're older. Yeah. But emotionally, I just can't keep feeling like I'm a bad mom. Like I can't keep feeling like I'm giving my kids something that's going to hurt them. Or in some situations, I can't keep hearing my friends say, gosh, I can't believe you let your kids drink juice. And so in those situations, it was actually a driver because the social environment was already doing something different or had already made the change. But you're right. Those are really hard. Yeah. And I even heard parents say in some cases that the driver was they were likening soda to drugs, either that they were observing their kids having addictive behaviors around them, or they were concerned that soda was going to be a gateway to drugs down the line.
Oh, wow. Well, I will post the study in our show notes. So listeners that want to take a look and learn more. So last question, Professor Christensen died 5 years ago around this time. What do you think would surprise or interest to him most in how healthcare specifically, how things have played out in that time?
Yeah, that's a great question. And I'll say that I can't possibly answer it the way that Clay would, but I think from what I learned from him and what I would hear him say over and over again is, my opinion isn't what matters. It's the theory's opinion that matters, or it's the theory that has an opinion. And I think that he would see a lot of promise in the health innovation, some of the ones that we've discussed today and in others, especially what innovators and entrepreneurs are doing despite the challenging environment that is innovating in healthcare. And I think he'd also say, like he wrote about in Innovator's Prescription, the system is continuing to limit how we frame innovations because the system is forcing some potentially disruptive innovations into a more expensive and a more sustaining trajectory rather than a truly transformative one. So there have been lots of great breakthroughs, but we're still paying for treatments and not cures, and we're still constrained by the system that we have. But at the end of the day, Clay was one of the nicest, most humble, most encouraging people I've ever met. And so I think he'd continually be encouraging innovators to trust the theories because of their predictive power and not to give up.
I love that. Well, Ann Somers, thank you so much for joining us today.
Thank you so much for having me. This was really fun.